Hello and welcome. My name is Michael Greco and my colleague is Jocelyn Lockyer. We'll just quickly introduce ourselves. My background is a professor in the area of medical education, and I've been in the space of researching and supporting clinicians with multi-source feedback over the past 15 years. It's something very passionate about. It's something I find that clinicians really value, and we'll be going through some of the tips, and Jocelyn she'll tell about herself in a minute, and we'll both be going through some tips about how to support you when you're conducting your debriefing sessions, whether in a formal way as a trained coach or whether in an informal way in terms of peer discussion, what we call a supporting medical colleague. Over to you, Jocelyn. It's lovely to see you. Jocelyn's all the way from Canada, and I think it's evening there. It's morning here in Australia. Welcome, Jocelyn.
Thank you, but it's summer in Calgary still, so that helps. Yes, I'm a professor emerita at the University of Calgary Cumming School of Medicine. I got involved with multi-source feedback in the mid-90s and worked with the Physician Achievement Review Program of the regulatory authority in my province of Alberta, as well as with the Medical Council of Canada and the National Board of Medical Examiners. Subsequently, I did get involved in the development of the R2C2 model, which we will talk about in a bit.
Thanks, Jocelyn. So what is multi-source feedback? Some people refer to it as 360-degree feedback. Others refer to it as MSF. And in Australia, we're now hearing the term multi-source feedback. And I guess generically, it's really about giving clinicians feedback in a structured way that they wouldn't normally get in a sort of structured way. It's around what patients think of your communication skills, and also what clinicians think about you, and even non-clinicians about your professionalism. So it's that sort of holistic view in a structured way of those skills that we don't usually get feedback. We might get feedback on our referral patterns or the way we undertake various consultations, our diagnostic skills. But usually our communication skills and our professional skills, the way we work within a team, the way we self-reflect, the way we carry ourselves as doctors is something we don't normally get feedback. So that's what multi-source feedback gives us, structured feedback. And as I mentioned earlier, it comprises of, in terms of the structured feedback, 3 components: patient feedback, and that's conducted by a question. All these are by questionnaires. So what is the patient's experience of my care? How do they see me? It's also colleague feedback. So these are a group of both fellow clinicians, whether they be medical or non-medical, and also administrative and managerial folk as well. Really the whole care team providing feedback on how they see you as a professional doctor. And there is a third component that's very important, and that's the doctor self-assessing themselves. It's important that they have an opportunity to reflect about their performance. So that allows us then to see how is the doctor viewing themselves compared to how others view them. And you might be asking, well, why is all this important? Well, it's very important in the Australian context. The Medical Board of Australia have produced a professional performance framework, and many of you will know as debriefers, whether formal debriefers, trained coaches, or supporting medical colleagues, that we are seeing a change in the structure of CPD, continuous professional development, that each college now is asking their doctors to undertake 50 hours of CPD per year, and that 50 hours is not just attending lectures for 50 hours in the year, but has to be broken down into 3 areas. And what multi-source feedback does is pick up on 2 of those areas, which is reviewing performance and measuring outcomes. So they're 2 of the 3 domains. The other domain is educational activities. So multi-source feedback will pick up on 2 of those domains. Specifically, the patient feedback picks up on measuring outcomes, the patient experience element, and colleague feedback picks up on the reviewing performance component. So the Medical Board of Australia's professional performance framework is asking clinicians to better self-reflect. It's changing the structure of CPD, and multi-source feedback is a key component within the new agenda going forward from January 2023.
Okay, so I'm going to talk a bit about the R2C2, and I know that sounds like a bad movie or an old movie. It's a coaching and facilitated feedback model. Now, we call it a facilitated model, and we also talk about it in stages, but actually it's an iterative model, because sometimes when you coach, you get stuck, or you need to zing back and rebuild the relationship. So there's 4 steps. The first step is really making sure you have a comfortable relationship. Next step is about exploring reactions and reflections, confirming content, and then coaching for change and co-creating an action plan. And I'll talk about each of those in the next few slides. My colleagues in, well, actually more than Canada, US, there were folks from the Netherlands as well, and the United Kingdom did a study around, well, 2010, it was a little bit before that, and said, how do people self-assess anyway? And we did focus groups with medical students, with trainees, and with licensed physicians, trying to understand how people self-assessed. And what we learned was there was buckets of information that came zinging at doctors all of the time, and medical students and trainees as well. Some of it was external, reports that people got, feedback from referral letters. Some of it was just, boy, didn't do well today, I just don't feel very good about it. What we figured out was that the doctors interpreted the information. In some cases, they reflected on it. Other times, they compared it with other data to see if it was valid. Sometimes they calibrated it or filtered it. Sometimes they assimilated. In the end, they made a decision, and sometimes it was to ignore the data. There was stimuli always. Let's just ignore it. Sometimes it was rejected. Sometimes the doctors sought other information to confirm, and sometimes the doctor accepted the data. But what we found out was there's a context to it that also affected responses. The context involved tensions, how I felt about my colleagues, and how I felt working in that environment. But there were also external conditions, including what the climate was, people's emotions, their confidence, and the perceived credibility of the feedback. All of these also affected how people used their feedback. And we did have a component of that study that did involve multi-source feedback. It wasn't only, there were other stimuli as well. So we put our heads together and said, just a second, and this was led by Joan Sargent at Dalhousie University. Goodness, you know, it appears that people don't have a very structured way of helping other doctors, helping trainees or medical students understand and use their data. We began to build a model, and there was a fair amount of research and theory we drew on. One is, of course, the self-assessment work that I described. Other is the person-centered approaches. And for those of you who are in practice and have been doing motivational interviewing, motivational approaches, you understand how important it is to be person-centered. But there also are cognitive domains that influence a behavior change. These are things like physician, their doctor's skill, their behavior, whether they think they can do it. Those types of things also affect the physician. We knew from continuing medical education work that there was that if we could get people to commit to making changes, they were more likely to make the changes. And so that's why the fourth stage is around that coaching to get a commitment to change. There's also an aspect out of implementation science, which tells us just how critically important the facilitator is in helping the doctor make sense of their data. Because, multi-source feedback data is simply data. It has to be interpreted and seems to work best when there is a coach or a supportive person who can help the doctor make sense of it. So the R2C2 model is designed to help the doctor reflect on their performance, assess their work, promote feedback acceptance, facilitate a direction for improvement, and then coach or facilitate to get the change. So lots of research. I think there's half a dozen publications that our research group has done. And then there's other work that's been done elsewhere, including work that Michael was involved in with Michael Pooley in Australia. And we're quite thrilled that others have picked up on the model. What we've found out, though, is that the model works across disciplines, works across different levels of training and different formats. It facilitates feedback, but the facilitator has to be attentive to both the content and the process. By content, I mean your job as a coach will be to go through the physician's data, the doctor's data, help understand the data well enough that you can have a conversation with the doctor, but then be attentive to process things like listening, encouraging, asking open-ended questions. What we've also found is that coaching helps to co-create a plan, and it moves away from assessment and judgment to development and progress. And in fact, we found in a couple of studies that if you can co-facilitate the action plan, you're more likely to have it implemented than if the doctor alone comes up with a plan, or if the coach comes up with a plan, it's not as successful. But we also know that it requires documentation, and that some people will require more direction. And we certainly like to think of this as a very democratic, egalitarian model, but the truth is not all participants will have the same ability to think through their data and come up with an action plan. But with a little help, they can get there. So the 4 stages, and I mentioned them before, but they are build a relationship, explore reaction and reflections, confirm the content, and coach for change and co-create an action plan. So let's look at the first stage, which is about the relationship. Beginning the relationship, it's helpful, important, absolutely critical that the coach talks about themselves. You know, I've been in practice for X years. I've worked in such and such a setting, so that there's a level of trust. Talk about how many sessions you've done or how many doctors you've worked with. And then, even though you may have a bit of data or understanding about that work setting, it's also useful to ask about it, because you may be surprised at the things that the doctor is doing. If it's a resident or a trainee, somebody in training, you might also ask about their program, the current rotations, how well they're doing. And if you're not getting very far, you can also ask them about their experience in preparing for the assessment. But whatever you do, really try to work hard on establishing a relationship at the get-go, but also, if you need to, come back to it. Then the next stage, you're really trying to get the reactions to and reflections on the report. There'll be many doctors who will never have seen a multi-source feedback report in the past, or have had that experience. And so what you want to do is to make sure they feel understood, but also that you're respecting them. So start open-ended. What struck you about the report? What were some of your initial reactions? What were the surprises? Did the data you found out, was it aligned with how you thought about yourself? And sometimes you just have to say, well, you know, sometimes we get feedback that just isn't the same way we see ourselves. In the third stage, really your task is to explore the doctor's understanding of the content. What does it mean? What do they think are the priorities? Were there things that didn't make sense, or they were unclear about it? While I discourage you from going through it section by section, there may be occasions where you have to. But the goal here is to really identify the things that you can work on to co-create the action plan, because in coaching, you're really trying to enhance their learning and development, and you're trying to create it in a supportive and encouraging environment. So here in the coaching stage, you're really getting at the plan. So you want them to identify changes, but you also want them to identify changes that are, we would call SMART goals, specific, measurable, actionable, timely, certainly goals that they can do, that are feasible. And so if somebody says, well, I'm going to implement an electronic medical record system in the next 3 months, that's probably where you draw a deep breath and say, well, let's maybe be a little more specific. Or if you have the trainee, and this is a common one, oh, I get feedback that I don't know enough. I'm going to read every morning about all my cases. Well, maybe that's not what you want. Maybe you want them to cherry pick some of the areas that they don't know very much about, but also to recognize that that might not be as feasible as they think. So it's really identifying the changes they want to work on, starting and doing them sequentially. So what is the first change? How would you go about doing it? What kind of a timeline do you have? And particularly so that you will see results. Get them to talk about the resources they'll need. Resources may be equipment, but it's just as likely to be other physicians, maybe feedback from nurses. Perhaps it's feedback from a more senior trainee, whoever can observe and see how they're doing so that they can get that feedback. And then you really want them to think about barriers, but also enablers, so that they're approaching this in as practical a way, and so that they will see success at the end or in the next stage. So just to reiterate, we are talking about a four-stage model that includes building the relationship, exploring reactions and reflections, confirming content, and then coaching for change and co-creating an action plan.
So this particular session is some information around how we might provide an informal debrief. So typically this would be provided by a supporting medical colleague, which may be a trusted friend of the doctor or a peer. So someone where it's not being conducted by a trained coach. So these will be some ideas around how you might construct that informal debrief. The role of the supporting medical colleague or the peer really is someone who can, whilst not being an expert in providing a debrief, can help the colleague pinpoint some positives in areas where they may need to improve. And it's really, as we said earlier in the earlier session, so important that the results are not just looked at by the doctor, but an opportunity to share that with a trusted colleague. And in this case, it may well be, as I said earlier, a peer or supporting medical colleague. And just to reiterate that the process of multi-source feedback is where the candidate would receive patient and or colleague feedback, usually 30 patients, usually 12 colleagues. So that's 42 independent assessments of a person's performance around interpersonal competencies and also around their professionalism. We mentioned the importance of a validated tool to do this. You know, it's not just enough to put some words on paper. It should be a validated tool that has been, you know, researched and also provides good benchmarks to support that doctor. And once they've received their report, there's this time of a debrief, and this is what we're talking now, an informal debrief, where it encourages the doctor to reflect more on their report in the presence of another person. And then resulting out of that self-reflection, there's an action plan developed, and also there's CPD allocation for those doctors requiring CPD, which was discussed in the first session. And these sessions are iterative, so you can go back and forth and look at previous sessions as well. Very quickly, it's important that we understand the framework on which we're hanging this particular debrief, and it's around those 4 points of the R2C2 model, where we spend a little bit of time about the relationship, building that in terms of sharing what you do as an informal debrief in terms of a supporting medical colleague, a peer, and then explore the doctor's reactions to the report, confirm some of the content, what did they notice, what did you notice, and also the important part around the coaching for change or co-creating an action plan. So when preparing for the meeting, that might take place in a number of different ways, but typically you would have received the report, the doctor's report, and you would inform the doctor you've received it, and you would like to set up a specific time and place and to carry out that discussion. whether it be by Zoom or telephone or however, it might be face-to-face. And then it's important that you let your colleague know, and this might be by an email initially, to look at the report, to look at all the feedback, and to hopefully set some insights around what the report is saying. And I would also suggest to them that this is really an opportunity for them to focus more on the report in a safe environment, in an informal way, but a structured way to help them get the most out of the report. It's important that they know it's confidential. You really need to go into the conversation in a non-judgmental way, a curious way perhaps, emphasising that it's important for all professionals to continually learn. We're lifelong learners, and feedback on us as a person, whether it be interpersonal competence or our professionalism is very important. And that it's not really about them or judging them in terms of their personality, but really identifying the behaviours within a personal competency and professionalism. What's the report saying in terms of what we do well and what we might want to focus on for continuous professional development? So that's the context, that's setting the scene. And during discussion, it's important to have open-ended questions. As I said, that sort of curious nature. Tell me more about that. What did you make of that? Those sorts of questions are important to elicit the response. Further on in these presentations, you will hear about common scenarios that both Jocelyn and I have come across in our many debriefs, and that will be important for you too, as an informal person, as a person who's conducting informal debriefs, to get a sense of what you might come up against when in those debriefs, or the types of scenarios that may arise. And I think one of the key things here is to do less of the talking if possible. Allow your colleague to guide the discussion. And I think open-ended questions allow that, and that attitude of I'm keen to learn from you how you perceive this report and where you feel the learnings are. So the less you can say in one sense, the better. And as an informal debriefer, you will, that might be a challenge initially, but I think you will find the tips that we're discussing through these series of seminars should be very helpful. The report is quite extensive. It provides an introduction and some graphical overview of results on the patient and or colleague feedback. I say that because some of your colleagues may have just had patient feedback or just colleague feedback, but typically a multi-source feedback would include both patient and colleague feedback. There's some self-assessment data where your colleague would have commented, usually on completed the colleague feedback component in terms of how they've rated themselves. And there's also some guide for performance reflection and supporting documents in the report. I would familiarise yourself with the report. You know, once you've done it once or twice, you will know it inside out, and that's very helpful for when you come to review other reports in your discussions with colleagues. I mentioned about the graphical overview of results. This is a snapshot. You'll see here both patient and colleague feedback. And you can see if we look at the patient feedback, there's a range of scores from all the benchmarks. So that's the grey coloured horizontal bars. But in those horizontal bars, there's a vertical blue line. That's the median scores of all doctors who have undertaken the patient feedback. So the norms, if you like. And the black crosses are the candidates' scores from their patients. And you can see in this particular case that the candidate has done very well with their patients. In fact, I think in every item, the 13 items, they're above average. So that's quite positive. And you'll also notice the items of the patient feedback tool, apart from questions 1 and 13, are quite focused on behaviours like, warmth of greeting, listening, explanations, the way they reassure people, the way they respect them and allow patients to express their concerns and fears. These are all behavioural elements. So hopefully that provides some material when you're discussing the report. In this case, very positive. And one of the tips, or not so much tips, but common scenarios we come across, and you'll hear about this in later presentations, is when the report is exemplary and the doctor feels there's nothing to learn from this. And we've got some tips about how you might continue that discussion if it gets stuck around the doctor thinking there's no more they can do. But in this particular case, you'll see their colleague feedback isn't as glowing. You'll see that some of the black crosses are below the norms or the medians. Some of them are above. For example, question 7, punctuality and reliability, is above the norm. But there's quite a few of their scores on particular items that are below the norm. You'll also notice some white crosses there, which didn't appear in the patient feedback. Those white crosses are their self-assessments. So they've gone in, the doctor, and self-rated themselves on each of those items. And they will obviously, because it's only one item, they'll either be 0, 25, 50, 75, or 100. And that's why. And this particular doctor's rated themselves excellent or very good mostly. But the scores aren't representing that. So that's an interesting snapshot for me in having done quite a few of these. They do see themselves as very good or excellent, so expecting possibly a good report, and may be disappointed with this colleague feedback result where quite a few of the items are below the norms, and there may be a very good reason for that. And this is what the exploring and asking them for their initial reactions to the report is very important, because this is where they may focus on immediately, and you'll need to go with that. But we don't want to forget that they've also done quite well with the patient feedback. So it's just being aware of that, and part of your preparation as an informal debriefer is to look at the report before you have that debrief with your colleague. There's quite a lot of quantitative data in the report. Here's the patient feedback. There's all their means are well above average, in the 90%. You will find doctors in the 80%, sometimes 70s, and 80% sounds quite positive, but it's important to realise that patients do tend to rate doctors quite highly, around that very good to excellent. A little piece of research that's around that suggests that very good's not good enough. That was some research done in the UK where they explored ratings from patients, and then they went back and interviewed patients who had rated their doctors very good or excellent, but found there were some issues. So the ratings, I think high 80s, maybe early 90s, very positive, but sometimes there's still maybe some areas for improvement and learning. So you'll see there graph 1.1. I often look at the number of excellence, and there I think it was question 4 that had the least number of excellence, still very good. And that was around their quality of explanations to the patients. There might be a comment around that, and that's worth having a look at when you look at the report, not only the numbers, but also the comments that may support the numbers. So that's something you as a debriefer will need to look at. The colleague feedback, it's quite a similar structure for patient and colleague feedback. The colleague feedback has quantitative data as well. In this case, I've just brought up the piece around the actual frequencies. And I often look at both the poor fair columns, making sure there's no ratings there. In this case, there is a 1 rating on fair. It might be the same colleague who's rated questions 8, 9, 11 and 13 fair. And that's, from my experience, not so typical. There is a poor rating as well under ability to manage stress. Not so typical to have a poor or fair rating, but again, there might be some comments that support that, and there might be some reasons for that. And it might be something the doctor may comment on as well. And I often look at the excellent column as well. Where are the highest number of excellence, punctuality and reliability? Where are the lowest numbers of excellence? Around ability to say no is the lowest, and also teaching and training of colleagues. So there might be some reasons for that. You might want to, as I said, in your preparation, just circle that. That might be something you may want to bring up. The discussion may not go down that track, and that's fine. But I think if you think it's important, then it might be something you bring up during your discussions. Here again are the norms and the medians. This particular person has a few scores between in the lower, sort of between that 10% and 75% percentile. But again, I think there's enough quantitative data for you to draw out what might be worth looking at here. But please be guided by what's important to the candidate. The self-assessment of data, as I mentioned previously, this particular doctor has rated themselves very good or excellent. So potentially expecting a good report on their colleague feedback. And in this case, the report is really to inform, and it's not a summative report. It's really a formative report to help guide the doctor about things they do well and to keep doing, and about things that they might want to focus on and improve. So I think this report that's being presented here would make for an interesting discussion. I think what I was just quickly looking, I couldn't see any, I apologise, there's any qualitative data in terms of comments, but the reports will have comments, and that's important. And sometimes I've found in the debriefs that there's a lot of discussion around the comments, because you may get comments that are repetitive. So various colleagues are saying, various raters are saying the same thing, and that's usually quite helpful for highlighting. It might be areas of strengths, and sometimes the doctors don't see it. I remember I had to inform one doctor that the word approachable, in terms of positive, they were approachable, had been mentioned 12 times in their comments, and they hadn't noticed really the significance of how. And I asked them, what makes you approachable? And that allowed them to reflect on that. And I said, well, keep doing it, because your scores, are showing that that's one of your strengths. So the report is not something about let's find what we can do better. It's more than that. It's building on strengths and also what might we do better, and that's the change for action. And there's also even a performance reflection guide, what we call a ready reckoner. This one in front of you with the dots. I found quite a few doctors have found this helpful. It also gives a description of the skills. That's the vertical columns. So if there's a particular patient rate, in this particular case, the doctor did quite well. But if you were to choose, something that was low, for example, when I say lower explanations, there are some skills that the doctor might want to focus on. Ask before tell is a beautiful little skill, and it describes it in the report. Just quickly, that just says, before advising a patient what to do, you might want to say something like, I have some information that might be helpful for you in managing your condition. Would that be helpful for you if I shared that. And it really is a respectful way of providing information, ask before tell. And it's really a sharing of power too between the doctor and the patient. So doctors have found this quite helpful, and those skills on that vertical column are all research evidence-based skills. So just that's in the report to help the doctor reflect as well about what they might do differently. And hopefully they would have read the report before they've met with you. And then there's the action plan, which really is something that the doctor needs to come up with 2 or 3 ideas about what they might do going forward. And it might even be doing more of what they do. Typically, though, it's more about how they might improve and do things. And this is co-created with you as a person who's debriefing them. And look, there might be some occasions when they might be blindsided, perhaps, for want of a better word, in terms of something that the results are saying, but they can't see that. And we have some suggestions around that in later scenarios in terms of what we've come up as debriefers, some common scenarios with doctors. So in preparing, think about the R2C2 in terms of spending a little bit of time letting the doctor know what you do. I think if you're a trusted friend, obviously they'll know who you are, so the rapport is already there. Wonderful. Asking them, what was it like getting your report, receiving it via email, opening it up? How did you feel? You might even want to explore, the people that they chose to rate them. A mix of people, who did you choose? Not names particularly, but roles. How did you find the report when you first opened it up? So I think it's important to get their reflections, and that might drive quite a bit of the conversation as well. And then the content, as we just described, as I went into detail just during this presentation, you need to have a good grasp of that. Sometimes a doctor may need some explanations around some of the content, and if you've been able to, which you should have, read the report, you'll be able to support them with that. And then that piece, that 10-minute piece at least towards the end of your debrief, where you're asking them, so what might you do going forward? What plan would you like to put together going forward that you're going to work on in terms of your continuous professional development or improvement? And it's important that you explore that with them, even to the point of not just allowing them to say something like, I want to become a better communicator. You need to ask them to, and there's some points around this during these presentations, drill down on that. How might you do that? When might you do that? How will you know if you're successful in doing that? So the coaching for change is really important, and I'd encourage you to support the doctor in that process.
So we're going to talk about some of the pearls and tips for providing a multi-source feedback debrief. Just a reminder, we're still dealing with the R2C2 model, in which you are building a relationship, exploring reactions and reflections, confirming content, and coaching for change in the co-creation of an action plan. So one of the most important things is to prepare, not only to prepare the doctor and let them know what the expectations are, both beforehand, however the communication goes, but also for you yourself to prepare before you begin to do coaching. That really requires that you read the report. And of course, the first few that you do will be a bit slow. but they get easier and faster because you'll know the data, right? Think about areas that you might discuss and jot these down, right? Because that way you can draw on them as are necessary. The physician may well come up with a good slate of topics that the doctor wants to talk about, but it's helpful for you to have some things. As Michael mentioned in a previous session, sometimes the doctor wants to go to the negative and the things that are troubling, but you really need to be able to also talk about the strengths. Did you notice that? You know, is there anything that surprised you that was particularly good? When I looked at the report, I noticed this. So you're going to want to draw on those things. So jot down what you see are the strengths, but then also jot down concerns. If you're working with a trainee in particular, you really want to be attentive to issues of patient safety, issues of competence. You may spot behaviors, particularly in narrative, not always in the quantitative data, but often in the narrative data that suggest maybe problems with teamwork or collegiality. Sometimes nurses will say things like, I wish the doctor would let us do X, or the physician needs to trust the nurses to do Y. Those may well come up, and you want to be thoughtful about, maybe there's an issue here with how the physician works with others. You also want to be thoughtful about signs of burnout or stress. The last thing you want to do is be aiding and abetting physicians leaving the profession, right? But sometimes doctors get themselves into a bind where they're working far too many hours, seeing too many patients, and you want to be able to be thoughtful about that. So as you prepare and read the report, jot down your ideas. And then think about the environment. Now, most of these will be done by Zoom, possibly by phone. If you're working with trainees, you may be doing a face-to-face, depending on your setting. However you're doing it, you really want to be sure that the person is respected and they feel comfortable talking to you and divulging information that they might not tell others about. And that's why, one of the reasons why you want to find out as much about the doctor's context and background and work as you can, but also to share some of your own experiences. And then Michael said in another session, be curious. You know, this is about open-ended questions. And while you may have a long list of questions you can ask, be judicious. This is not a staccato performance where you zip through a whole series of questions, but, you know, take it slowly, initially, you know, help me understand. Get the doctor to critically reflect on their report, what they saw. And then as you look at the report, think about where the self-assessment score is quite different from the score that the colleague provided. That often will provide information. Look at the narrative. Is there something, are there threads in that seem to be coming from other physicians or non-MDs? And then be sure as you develop the action plan that it's feasible and actionable. And we talked about having SMART goals. Don't forget that you're trying to get their perspective and you're trying to support them in self-assessment in a guided way. there may be differences of opinion. The doctor may feel strongly that the assessors, the raters, have provided erroneous or incorrect information. And that, again, is an opportunity to explore why they think the scores they got were the scores that they received. And that may be a helpful way of helping the physician overcome some of the problems. Okay, this session is for doctors who are coaching or are supportive coaches. And what our focus will be on what happens when, because we all have fears about stuff stalling or having trouble with coaching. So what we're talking about now is the fact that these talking points are just meant to engage the doctor further should things stall. They'll help you move from the reaction and content stages into the coaching for commitment to change. And of course, as a reminder, and you can see the circles, and remember, this is an iterative model, so you may go back and forth, but you are building the relationship, exploring reactions and reflections, confirming content, and coaching for change and to co-create an action plan. So always think about when you get started, tell the doctor who you are, your credentials, the nature of your work, because you want to establish the role and also find out about the doctor's practice and interests. And that way you can draw on that as you go along. You will have reviewed the reports as well as the doctor having reviewed the reports, and you've jotted down some notes, and be sure to have them handy because you may want to and probably should draw on the strengths you've noted, and also have figured out 3 or 4 areas that you might identify for development. But sometimes things are funny. And we're not going to cover everything between Michael and I, but we'll cover a few of the things that we've found out. There is a sheet that is on the website, and you can draw on that for further cues and clues before you do coaching. So the first one is, what happens when the doctor's scores are exemplary? And, you know, everybody is anxious about giving feedback to someone who seems to be really quite perfect. But remember, Olympic athletes, golfers, skiers all get feedback to tweak their practice. And so really push and encourage the physician to identify areas for improvement. Now, in some cases, this may mean going a bit beyond the report and the narrative and the numbers, and encouraging the physician to think about things that may make the office or the practice more effective and more efficient. Areas like research, extra teaching, new teaching, that committee work that the physician might want to engage in to enhance their commitment to medicine and their enjoyment of medicine and the practice of medicine. So, you know, don't give up, and certainly don't think that just because scores are exemplary, there's no need for probing and encouraging, aiding and abetting. We've got another one on doctor scores suggesting deficiencies. We're not going to talk about that, as Michael will tell you from his hundreds of doctors that he's coached. It doesn't come up that often. I know that's a concern, but certainly one where we've got some ideas on the guideline sheet. you want to take this one?
Yes,
Mike?
thank you, Jocelyn. And just to reiterate that there are lots of common scenarios that do come up, and your notes will be able to describe some of these scenarios that we've put together. And just to, Jocelyn, the one about the exemplary, I often, because you will get a lot of doctors with good reports, I often ask them to describe what they do in a consultation that generates such good scores. So getting them to think about what they do well and to do more of it, and get them to describe that. It's often interesting. Sometimes you get a bit of silence and they're not quite sure what they do. But then once you can open up that discussion, we start exploring those exemplary scores and what they did well. And in this particular case, which it does happen, where the doctor wasn't prepared, when you ask them what reactions did they have to report, you might have a doctor say, I actually haven't read the report. And I think in that case, you could suggest that maybe this isn't the best time to discuss. That might be important for them to have a look at that report, and could we reschedule perhaps that meeting so that we can get the most out of the hour debrief. Otherwise, I think it would be, my experience is it's been difficult to get value when someone really hasn't picked up a report and had a look at it in the first instance.
It's rare, but occasionally there'll be a doctor who wants to focus on the positive without solutions for areas needing improvement. And again, what you're going to do is have your short list of items that the physician might address or think about, and you've gone across the data and looked at the narratives. And so you may have to be a bit more directive here. And this is similar to what happens when a physician resists making changes or suggesting a way forward.
When the doctor is angry, upset, that can be a little awkward. But I think this could be rich for learning, actually. And I had a recent example where a doctor was upset about their results, not so much the patient feedback, but the colleague feedback. And I just asked, you seem disappointed in what was being said. And because we built that rapport initially, and we spent some time, me listening to her, the particular event came up where she shared with me that she was feeling somewhat bullied in her work environment and not appreciated by one or two people in that particular clinical setting. And it became an opportunity just for her to vent those feelings, and it made sense too about some of the suggestions that were being put forth. And one of the suggestions that was quite strongly being put forth was to become more assertive. She found it very difficult to do that, given the work environment, but also because of her cultural background. She said in her culture, it was seen as somewhat rude to be assertive. I guess that's how she saw it. So we just talked a little bit about what being assertive might mean in the context of her work environment. And that became a learning point. And I think most of the discussion around the multi-source feedback results, particularly the colleague feedback, because she did have a lot of positives from other colleagues, was how she might be able to tailor her assertiveness in a way that was true to herself. And she could, at the end of that, and it was lovely and surprising, she could see a way forward that she was going to put into practice, which capsulated some of the feedback and the qualitative comments about being a bit more forthright and speaking up and not being too softly spoken. These were things that she wants to do, but just wasn't quite sure how. So she, I was able to point her in the direction of some, just general assertiveness training. You can Google assertiveness. We just talked briefly about what's the opposite to assertiveness. So it was very, very sort of high level conversation, but she had specific things she wanted to do as some actions at the end of that particular debrief. So when a doctor is angry or upset, I think explore those feelings a bit with them and see where that gets you to, because there might be something there that comes out during that discussion. As I said in a previous session during these presentations, that these are quite debriefing sessions. They're touching on the person themselves, getting feedback on one's interpersonal competencies and one's professionalism is very personal, and it touches deeply sometimes. So therefore, the conversations can be very rich around purpose and around how they can become better in those areas. Thank you, Jocelyn.
Now, occasionally, a discussion will get sidetracked, and I think you have to weigh that as you go along. Is this a problem? Is this not a problem? As Michael described, the physician who was angry and upset, the R2C2 model is one in which you may have to swing back to making sure the relationship that you have with the doctor is working, and so that the doctor can talk about what's going on, and then proceed back to the reaction and content. So it is iterative and can go backwards and forwards. I mean, you will have told them at the beginning that your goal is to come up with 3 action plans. And so you do want to stay the course on that, but be flexible if you need to. Yes, this is when nothing is happening very well. And you're thinking, my goodness, now what? Well, I think sometimes you say, well, look, we've done 1 action plan, we've done 2, our hour is up. I think we need to either come back or leave it at what you've got. Depends on your circumstances as the coach. Okay, in this section on multi-source feedback, we're going to talk about what you'd actually say when you're debriefing trainee doctors and you end up with a glitch or 2 or a challenge. And I'd like to preface it by saying that trainees are a bit vulnerable. They may be very vulnerable. And there's always a power differential, particularly if you are their supervisor or are otherwise evaluating them. There may be levels of discomfort that are in place regardless of what you say or do. And so it's important, of course, to set the expectations, but it's also important to recognize that there can be challenges based on gender, ethnicity, the trainee doctor's school of graduation or country of graduation, age. Many things may contribute to the vulnerability. We're not saying that you shouldn't do coaching. We absolutely think you should do coaching, but to be attentive to some of those vulnerabilities, particularly if things seem to stall or the trainee isn't particularly forthcoming. So when you're working with a trainee doctor, and we're just providing some points that will engage the trainee if the conversation stalls, and they help you move into the reaction and content stages. And of course, you do remember that the model is based on the relationship, exploring reactions and reflections, confirming content, and then coaching for change so that you can co-create an action plan. When you're working with the trainee and trying to establish that relationship, and you may already have a relationship, but what you want to do is make sure that you set the agenda for the session, and that, you know, to make sure that everybody's comfortable, ask about current and past experiences, or ask how the current rotation is going, how the work experience is going right now. I think it's important because you will have reviewed the report prior to sitting down with the trainee. Make sure you've noted the strengths on the report, because while you want the person to improve, it's also critically important to reinforce what the trainee is doing well. And then once you and the trainee have determined your 3 areas for development, you want to proceed with coaching so that you can get a commitment and help the trainee be as specific as possible. What will they actually do? How will they do it? What's going to enable their success? What might present barriers for their success? And then have a timing in place and a follow-up plan. Now, it may not be you doing the follow-up. It may be asking the trainee to identify the supervisor on the next rotation who can give them feedback on their progress. But there should be follow-up, or a mechanism for follow-up. So the first, what would you do if, or what would you say if, is you have a lot of data and it needs to be prioritized. And sometimes that is just the way these reports go. There's a lot of narratives. Sometimes they conflict. Sometimes there's so many ideas that you could have for action plans, and you can't do it all. Really give some thought to, are there issues of patient safety that you're concerned about with the trainee? If there are, that would be an area that you'd really want to make sure that somewhere in the action plans you begin to address that. But you might also have concerns about professionalism, communication skills. Make sure that you identify what you think are the most important, and so that the discussion can focus on them. Because there's no way a trainee can leave a session like this with a long list of 12 things that they can improve. 3 is about all we can handle. And, you know, ask open-ended questions. When I read the report, I thought about, or I noticed that, what are your thoughts about this? So there's certainly ways to get at it in a gentle but effective, and sometimes you have to be more directive than not.
I think, thanks, Jocelyn. There may be occasions when the trainee is not prepared for the discussion. Now, you would expect that in a training environment, the message around multi-source feedback would have been communicated in a way that says, when you receive your report, please spend some time looking at your report, using the reflective guide in the report to further understand your results, and that the trainee would have prepared for the discussion with the trained coach or the supporting medical colleague or the GP supervisor or the medical educator. So you'd expect that would be that this may not happen, but occasionally it does. And if it does, and the trainee, for example, hasn't had time to review the report, it might be worth rescheduling that appointment to ensure that there's value in the debrief with the trainee. I mean, you may want to ask, what got in the way of not being able to debrief your report. I wouldn't focus on that too much, but it's more about we'd like to get value. I want to support you in understanding these results. We need to give it the dedicated time, and you need to give it the time to reflect on these results, because they're quite valuable results in the sense that they provide a lot of insights. It's not just, for example, one person providing insight. It's 42 or more people providing insight, 30 patients at least, and at least 12 colleagues. So rich information that the trainee can draw on. And if they haven't had that time to reflect on that report, I think you might be better rescheduling the appointment for the debrief.
It's rare, but occasionally you get a trainee who wants to focus on the positive without coming up with solutions for areas that need improvement. I think this comes up most often when you have a trainee who's afraid of losing face, or a very vulnerable trainee who isn't able to reflect, perhaps trained in a different setting where the doctor always knows the answer, and it's hard for them to deal with recommendations and suggestions for improvement. There are sometimes, if you are a physician yourself and doing the coaching, you might remind the trainee that we're dealing with a growth mindset. We all have areas. If you're comfortable, you can share some of the areas you personally are working on. So to normalize the effort of improving and continuously. You might also state something like, I see from the report you're doing reasonably well, but we can all grow as doctors and must keep critically reflecting on how we're doing. But when I looked at your report, there are a few things I noticed. Well, what are your thoughts about these particular things? And then push and be a bit more directive about how, first of all, they have to acknowledge this may be an area of interest. We know from the research that co-development seems to lead to more likely implementation, but push to get an agreement that that's an area that they'll work on, and then work out a plan for how they'll do it and when they think they will be successful and will know they're successful. Now, occasionally we get a trainee who is angry and upset, and sometimes you just have to work through that and figure out why they're angry and upset. And it may be related to some of the power differential. It may be related to something that went on that day. And if you can figure out what's going on, then, and you feel you can do a successful session, proceed. If you don't, if they've had a patient who's died that day, that they unexpectedly, some family tragedy, you might just want to back off and reschedule the session when it can be a productive session.
Yes, occasionally. Thanks, Jocelyn. Doctors may get some negative feedback from non-doctor sources. Now, some reports, the report, depending on the type of multi-source feedback that the doctor receives, or the trainee receives, some reports have a breakdown of doctor versus non-doctor scores, but the comments, I've found that some of the trainees, they may know who's provided that particular comment, and it may be a non-doctor. And it may be, I haven't come across this too often, where they may want to dismiss that particular comment because it's a non-doctor. And I would often explore with them, what makes them say that. In the framework of we can learn from all sorts of people in a care team, that we are team members and everybody within the team is important. So, but I would like, it's more important, that's me giving advice, but I'd want to hear from that trainee what makes them think that the non-doctor source, say it's a nurse or a practice manager, it provides feedback to help that trainee do better. What makes them think that's less valuable? And that can be an interesting discussion in itself and open up some conversation that in a positive way may lead to some things that the trainee sees that they could improve. Because a lot of the multi-source feedback, whilst there's some questions on clinical ability and clinical knowledge in the colleague feedback, most of it is really around the way, their manner, the way they operate as a person within a care team and with the patient. So these are sort of, in some ways, humanistic skills, not hard clinical skills that people will comment on. And that's what the multi-source feedback is picking up. It's providing a workplace-based assessment that is quite different from other clinical assessments, which are important, obviously, but the multi-source feedback fills a gap within that plethora of assessments for the trainee in a sort of formal, structured, validated way, both patient and colleague feedback. So hearing from non-doctors is really important. So you as a debriefer will know that. So if you do get that comment from the trainee that, well, it was just a nurse that said that, then yeah, I would explore that further as a debriefer, and hopefully there's some learning for that particular trainee. So yeah, coaching an exemplary trainee. Is there such a thing as an exemplary trainee? Some might say yes, in the context of a trainee. Some may say that all trainees have areas to improve. Well, we could say that about all of us, couldn't we? So you as a debriefer, you'll know that we're on a journey of lifelong learning. We're all learners. And how do you coach a trainee who's done very well? Well, I think one of the first things is to acknowledge that they've done very well, and they hopefully can see that. Hopefully, I have had one example where they did extremely well, but there was one comment that just took the edge off that exam, and they wanted to focus on that one comment. Now, as a debriefer, your challenge is to acknowledge that yes, there is a comment around something that you're a little bit concerned about. There's also lots of other things, and the rest of the report is quite positive. So can we focus on that in the first instance and then come back to that? And they might say, yeah, why not? Yeah, let's have a look at those. I knew I was pretty good in those things. And that's why I would ask the trainee, So tell me a little bit more about what you do to get such exemplary results. What would I see you doing? What behaviours would I see you enacting to score high on the way you explain things to patients, for example? What do you do in a consultation by way of explaining that generates those high scores, or where you've scored highly in the way you've respected your colleagues? How do you demonstrate respect in your workplace? What do I see you doing or not doing? So even though they've done very well, I think it's important for the trainee to know why they've done well and how they do that, and to keep doing that. So, as a debriefer, you might want to focus on continue doing those things. And there may be some areas where you stop doing, and there may be some areas where they consider doing. So I think, it's all in the context of lifelong learning. We can all improve, but we can also all focus, and this I think is the point I've made in earlier presentations. The reflective practitioner is one who looks at what they do, both good and possibly not so good, and tries to change or keep doing what they're doing well, and to know what they're doing. That's important.
Coaching the trainee with many gaps is about prioritizing what you want to say, recognizing that you can only do so much in any given session, and you need to focus on those gaps that might suggest problems in the workplace, problems with patient safety. Now, occasionally you'll find a trainee who can't believe they have any deficits. They've always been rated nearly perfect on scoring systems. Perhaps this is a North American syndrome from our school system, where little children get gold stars and pats on the back, and only the brightest and highest achievers get into medical school, and they get 5 out of 5 on all of the scoring systems. But occasionally you'll find a trainee who just is in shock that they would get feedback that they feel is subjective and unfair when they've been very nearly perfect their whole life. Again, it's a question of what have you figured out from the report? Don't forget their strengths, but also be somewhat directive in identifying areas that they can improve. This is about being in a growth mindset and getting better, and reminding them that even Olympic athletes who are the cream of the cream have coaches and trainers and advisors, or they're not going to get that gold medal. And I think that most trainees will respond if you have an honest and fair discussion with them. So that really brings us to the end of our challenges, I guess, considerations if you are working with trainee physicians. And lots of resources are available to you. And we hope that you will avail yourself of them. There is a guideline sheet which covers many of the same dilemmas that we've talked about today.
Thanks, Jocelyn, and we wish you well in whether you're a trained coach in multi-source feedback debriefing, or a supporting medical colleague, trusted peer. Hopefully these resources that have been provided to you are helpful in that process. Thank you.